My name is Jennifer Kolker. I am a professor in the Department of Health Management and Policy here at the School of Public Health, and I also run Drexel's Public Health Training Center. And our goal in the Public Health Training Center is to basically train and offer knowledge to the public health workforce. And how you define the public health workforce is however you want to define it. For me, it's really anybody that's doing any kind of health and medicine, particularly in an urban area such as ours. So I'm thrilled to see all of you here. With us today, I am very pleased to introduce Dr. Mira Gohel. Mira Gohel is a family physician, obtained her medical degree from Jefferson Medical College, and completed a residency in family medicine and a fellowship in faculty development in the Department of Family and Community Medicine at Thomas Jefferson. She's with the Philadelphia Department of Ambulatory Health, which for those of you who don't know, and she'll probably tell us, runs 8 primary care centers throughout the city of Philadelphia, one of the few major cities left in the country that actually offers a primary care safety net to its citizens in need. And as long as I've been in Philadelphia, that has been the backbone of our public health system, that in this city, if you need care, you have a place to go. You may have to wait for it, but you have a place to go, and that's a pretty remarkable thing. And the only way that those systems work, of course, is with relationships with our academic medical centers. And as we all know, our emergency departments and our academic medical centers are also part of our safety net here in Philadelphia. Dr. Gohel has a long history of work both in family medicine, also in domestic violence within the primary care setting, and has done a lot of work in training of physicians and people in public health. So, just sit right there.
Hi, everyone. This is a pretty loose talk. So I will be happy to take questions as they come up, but what I'd like to do is just give you a little bit of information, sort of practical hands-on stuff about what kind of work I do. Oh, I'm sorry, Jennifer, I have until noon, or 1 or 1:15? You will come in, 1:15. Okay, all right, so we can take questions at the end. So we're going to talk about sort of my perspective on, providing health care for the underserved in Philadelphia. There are probably a lot of things I'm going to miss, but I'd like to cover a few basic things that I have learned over the years. I am the clinical director at Health Center number 3, which is in West Philadelphia. So my role is not just providing medical services. I supervise the rest of the medical staff there, and I'm involved in sort of procedure and policy stuff, which is really big in government work. So, and it's really fun for me. But, I totally love my job. So, you'll get to sort of hear about the stuff and the challenges that I face, not so much from a bureaucratic standpoint, but in terms of trying to get care for patients. So some of it's a bit of didactic, sort of demographic information, but then we're going to move to case-based stuff where I can really show you where we shine. And 12.5% Black, non-Hispanic, 4.8% Asian, and then there are other areas, Native American and mixed ethnicities that I didn't include just for the sake of space, but those are smaller numbers. In the U.S., 15% of individuals live below the poverty level, what is defined by the federal government as poverty. And I'll just tell you now, in case you don't know, in 2010, for a family of 4, poverty was defined as about $22,000 a year, which is pretty minimal. And they don't adjust it in the continental U.S., they don't adjust it for where you live. So the level doesn't change whether you live in an expensive urban area or in a rural area. It's the same throughout. It is different for, I think, Alaska and Hawaii, but we won't get into that. As of 2010, based on some of this data, about 10% of all children were uninsured. Now, everybody likes to talk about, and it's important to talk about kids because they're and sort of what's going on with them, because they are kind of considered, part of the most vulnerable population in theory, and a society is supposed to take care of its children. If they're not going to take care of anybody, if they're going to take care of anybody, they should be taking care of their kids. So everybody likes to talk about what's going on with children. So in the U.S., about 10% of our kids are uninsured, and then more remarkably, about 15% of children who live in poverty are also uninsured, which is kind of a head scratcher to those of us who know how insurance works or insurability works. The kids, people living in poverty, should in theory be the ones who are eligible for insurance. So sort of keep that in the back of your mind as we talk about some of these things. But there are many reasons for this, and we can come back to it. I mean, one can speculate many reasons for this. But it really, this big a number, in my mind, based on the work that I've done, it shouldn't be this high. And there are things that we need to, we as sort of a medical community, a society, a responsible society, can try to do to address these issues. But again, these are just sort of markers. So Philadelphia, again, this Philadelphia data, I think is a little bit, it's between, the stuff I've culled is mostly from 2010 and some of it from 2012. Our population in 2010, based on U.S. Census, went above, actually increased for the first time in many years, and that was kind of a big deal. We've always been around for the last 10 years or so, we've been around 1.5 million, but we were dropping slowly, and now it went up a little, and it's thought that it may be due to a lot of the increase in our immigrant population. In the city, about 16% are, by self-report, are uninsured. So that compares to the rest of the country, which again is not anything to be proud of. It's still a big number, but we're not that far, off from sort of the national demographics. I just wanted to mention that about 10 years ago, PHMC, which is it's Philadelphia Health Management Corporation, it's a not-for-profit that does a lot of work gathering data and providing services, and they just do a whole slew of wonderful work. They did, I think this was based on one of their household surveys or something like that they do, where they found that 40% of Philadelphians were not seeking care due to their concern about medical costs. So it's not just the uninsured, it's people with coverage as well, but the coverage may be limited or may still have lots of copays and what have you. So a lot of our population is still not seeking care. 40% is greater than 16%. So they're not seeking care for lots of reasons. And those are the folks that we're, sort of looking at with a close eye to try to help improve outcomes, services and outcomes for. Other basic demographic stuff, about 37% of our population was self-defined as white non-Hispanic. Again, this is less than the national percentage. 42% self-identified as black, non-Hispanic, 12% as a Latino or Hispanic, 6% Asian, et cetera, et cetera. And again, the Native American and the mixed race were smaller numbers, and I just didn't put them up, and they've been consistent. If anybody wants to know, the Native American population, I think, was less than 1% in this city and nationally, based on U.S. Census. So in the city of Philadelphia, 25% of our population, all comers, live below the poverty level. Not so good. That number, if I remember correctly, is going up. And 36% of our children are living below the poverty level. Really not good. I will say that though this rate of poverty for children is the highest in the state, it is by far not the highest in the country, where we don't even make the top 10. Thank you very much. I think it's places like, if I remember correctly, Detroit and Cleveland. I mean, their numbers were like close to 50%. But still, very problematic and a marker for sort of health, potential problems in terms of health outcomes and that kind of thing. So now you kind of have a sense of where we're at and why this issue of healthcare to the underserved, which can be defined in many ways, but it's sort of a broad term that I use for myself. Why it's such a relevant thing, and we're working in medicine, we're studying medicine. I think we kind of get it, that it's a big deal. Let's talk about one of the, as Jennifer said, one of the safety nets in this city, and I'm speaking mostly about, for the rest of the talk, sort of some of the things that we do through the Department of Public Health, through our Division of Ambulatory Health Services that provides primary care and attempts to connect people to additional subspecialty care, so that you have a sense of what we do and what role we play in taking care of our communities, and particularly our underserved communities, our vulnerable communities. So we have 8 ambulatory health care centers. Can I just get a show of hands? Who has any kind of experience with or understanding of the work that the health department does in terms of primary care. Some of you. So I'm not, okay, yes, some of you I would expect would, but so I won't be overstating things because it sounds like a lot of people are not informed, so, or would like to be more informed. And I'm speaking from a perspective, as I said, of a clinical director at one site, and there may be things I might not be able to answer. And again, if there are questions, please ask as we go along. So we have 8 ambulatory care sites. We provide full spectrum primary care, so from prenatal to geriatrics. About 55% of our visits are continuity visits, meaning the patient makes an appointment, they come in to see their identified doctor, and you know, they get their chronic care and their health maintenance stuff. Yeah, and we have a pretty big walk-in population as well, and these overlap. You know, a patient who's continuity one day comes in as a walk-in, but we see a lot of, as you can imagine, more transient folks who come in for walk-in because they need some kind of acute issue, and then they move on. They may leave the city, they may never come back, whatever. On-site, one of the things that I think is really great for us, unlike other sort of primary care sites that are not sort of hospital-based, is, you know, from a long time ago, from the very beginning, I think, or close to the beginning of the development of, I'm not going to give you the full history, but the health centers were kind of, you know, became primary care sites in the transition in the, I guess it was the late 70s when Philadelphia General Hospital, we used to have a general hospital, was shut down, and they transitioned the care that was going on in primary care in the general hospitals to these these ambulatory care sites, which were at the time providing, you know, well baby immunizations and were very limited services. But they decided from early on that it was important to have one-stop shopping. And I think at this point, I always, you know, when I first started working for the health department, I sort of questioned that and whether that was the appropriate thing to do. And I will say that at least for our population, it definitely works. And I think for most consumers, it's a nice thing to have, you know, pretty much everything you need on site. So we've got pharmacy services, X-ray, laboratory, and you know, we have some subspecialty things and health education services, nutritionists, dental, podiatry. There are things I'm leaving out, and I'll be speaking of about as we go along through the cases. But social services, and then we've got a host of other things that over the years that have developed that may have been grant-funded, short-term programs. Some sites have limited behavioral health services. I mean, that is our big area of need. If anyone were to ask, you know, so what do you need? I'd say we need some behavioral health services for the uninsured. But that's another story. Let's talk a little bit about who we see in our numbers and things like that. In the last year, I guess it was in 2011, and this number actually seems low to me, but our data show that we served about 84,000 unique individuals, so different individuals throughout the system. So we've got 8 centers, and you know, combined we served about 84,000 Philadelphians. So really, even if all those people were uninsured, we're not serving all the uninsured. You know, other places are. You guys are. You know, there are a lot of people that are involved in this process. We had 340,000 visits in 2011. That number's remained somewhat consistent. I actually believe that most of these numbers would be much higher if we actually had the staffing that we need, and that's one of our big challenges. But you know, as it is, we still see a whole lot of patients. Most of them were appointed. Some were, you know, 1/3 were walk-in. Although that number seemed different from the one that I showed you before, I realized that, but I guess that's the most current data. And in terms of services, we have a burgeoning adult population. I mean, you know, we can't get enough of the adults. They just are, they're really, you know, we really don't have the capacity to see and provide the care that's demanded, that people need. So our capacity, the demand certainly exceeds capacity in terms of adult care. That's not so true in pediatrics. 20% of our population and visits were pediatrics, and we're pretty much kids that need to be seen get seen in a timely manner. We do a very good job with children. I'm just wondering, I'll talk about this, but anybody have any thoughts as to why there's such a huge demand for adult services? And there's no wrong answer. I'm just wondering, based on maybe some of your own clinical experience or what you've read or what have you. Yeah, go ahead.
A lot of parents are working extra hard and overstressed, overwhelmed.
Okay.
Underlying medical issues.
Right. Right. So you've got people who might not have insurance that need to be seen. They're working hard, but they don't have coverage. They're stressed and they have a high medical needs. Any other ideas? Why would they come to, why would they come to us? Any other thoughts about that? Do you think that there's that kind of a demand in other outpatient settings? Just out of curiosity. Yeah, no right answer. I thought I heard somebody saying something. No? Yeah.
I think that a lot of people will see how they're coming to the centers. Kind of because you can get kind of like a one-stop shop.
Yeah.
You get affordable medicines.
Right.
Program.
Right.
Can't afford medicine.
Who put you in the audience? How do you know about this?
I'm doing my master's project actually.
Okay. Okay. Well, this young lady works in, apparently has a lot of experience at the health department, one of the health centers, Health Center 6, which is not too far from here. And she mentioned the PAP program, Patient Assistance Program, and I'll talk more about that. But the key thing that she also said, if you didn't hear, she talked about sort of the one-stop shop model, but also medicine, meds. They come to us because, well, for lots of reasons. We're great doctors, but they come to us because we can provide medication to people who, even though they may have insurance, the medication is still, there might be a copay, or they may not have prescription coverage, so we're going to talk a lot about that. Meds are absolutely critical, and why I believe there may be such a huge sort of demand for services, adult services in our centers. Yeah?
Kind of leads to a question, but I know here at as an ER resident, I frequently, on our patient's discharge summary, give a listing of healthcare centers.
Right.
I don't know how often they actually go.
They actually, that's great. If everybody heard, this is an ER resident who said that that they often discharge uninsured patients.
Those without primary care.
Or patients without primary care, with a list of all the public health centers, the ambulatory health centers in the city, and he wasn't sure how often they go. Now, I don't have. That's a great project. Hey, somebody, you MPH students, how many are actually, people are discharged with, you have the N, and then we would be, maybe be able to give you a feedback on how many actually show up. Try to figure that out with HIPAA and all that, but whatever. I don't know the numbers, but they do come, okay? Because, I'll be seeing patients, they come in to walk in, they have their discharge sheet from Hahnemann, from Penn, from Jefferson, and all the hospitals are doing it. So what I can tell you is they are coming. I actually suspect that the percentage is probably not high, of the ones who actually are able to follow through for various reasons. Some of the issues are probably patient-driven, and many of the issues may be our problems, access. So they are coming, but I don't know what the numbers are. But so thank you very much. Keep that up. I say that a little tongue-in-cheek because let me tell you, we see so many new patients coming from the emergency rooms or hospital discharges that are just, they have high needs. And the way I feel about it, because a lot of the staff will say, oh, it's another hospital discharge with all these, the list this long of meds, and they need PET scans, and they need this, and they need that. And I say, and they're just like, the staff will be beside themselves, because like, oh, more stuff that we have, not just that we have to do, but it's about capacity, and how much can we do, and how are we going to fit them in? And I say, this is what we're here for. This is what we do, so we have to prioritize. The ones that are doing okay, and they got their meds, and we don't worry that they don't get another appointment. They get their refills, they don't get another appointment for 6 months. But the ones who are very ill and need their PET scan and their follow-up with whomever, we fit them in. So thanks for asking that question. We will be talking a little bit more about that as well. Of the patients that we saw, you're a very informed group. I'm happy to see this. 50% of the folks that we saw in 2011 were uninsured, completely uninsured, based on our data. We did about, these are just sort of random, things that I was able to find I can share with you. We did over 400,000 laboratory tests. I mean, we're pretty high volume. We do a lot of work. And then I wanted to mention, I want to talk about, all right, so this nice young man, this young doctor sends, a patient to Health Center 6 or 3 or whatever, and the patient needs things that we can't do. You saw, we have podiatrists and we've got, nutritionists, but this person, the patient needs to see a cardiologist, or they need to see pulmonary for their COPD or whatever. So what do we do about that? How do we do that? Well, so we're primary care, but we have developed relationships, and this has been the case since I started working for the health department in long time ago, 90-something. The ambulatory health centers have contracts with the city hospital, so Hahnemann or Drexel, whatever. I'm sorry, I'm not exactly sure what you guys call yourselves as a hospital now, but is one of them at this point. It wasn't always, but it is now. Thank you very much. Or Penn, or Jefferson, or Mercy Hospital in West Philadelphia, or Temple has always been there for us, always. And what we're able to do with this contract is not just like, oh, could you please see our patients for free. It's not like that, even though some people act like it is. No, we have a contract with these folks, and we pay them at a good rate. Now it's the Medicaid rate for a visit. So if our patient that was sent to us by whomever, or one of our own patients, needs to see a cardiologist, the hospital gets the Medicaid rate. They're reimbursed by the city to see our patients. Now, again, there are some things we cannot cover. So if then that person ends up needing a cardiac catheterization, the contract, we don't cover that. There are certain things that we can and can't cover, but, their ongoing care, their stress tests, their, whatever, we cover all those things. So that's where we make the help, often it starts at the hospital level, patients are referred to us, we manage their primary care, and then refer as is medically appropriate to the contract hospital. The other thing about the contract hospitals is that, this is for the uninsured, by the way, only. Anybody with insurance can go based on, we act like any other primary care site. The insured patients can go wherever their insurance allows them to go. The other thing about contract hospitals, the way it works is so there isn't sort of complete confusion. The various hospitals have contracts with dedicated health centers. So I can speak about Health Center 3 and Health Center 4 in West Philly, and I'm afraid I'm not really sure which centers have Drexel Hahnemann as their contract hospital. But in West Philly, our contract hospitals are Mercy Hospital, Philadelphia, and University of Pennsylvania. And so our uninsured folks who need follow-up with the subspecialist are sent by us to those places. And there's a whole, sort of a bureaucratic process that generally works 9 times out of 10, where the patient is not billed, we take care of the payment, and it's, we get correspondence, and it's actually a pretty neat setup, and it works by and large for the most part in terms of outpatient care stuff. So if you guys have more questions about that, we can talk more as we go on. I just put a list of recently went through the department went through and just sort of listed our top 10 diagnoses. This is fraught with, this is fraught with limitations because it's based on encounter forms, and the encounter forms only allow so many diagnoses. But, it's your general primary care stuff. The one thing that I will say, which shocks me is not on here, is any of the behavioral health issues, which, are huge. But I think what happens is we can only code for 4 diagnoses, and by the depression, anxiety, all that stuff often gets put at the bottom of the list and doesn't make it to the encounter form. But it's the usual primary care stuff. How do we check up on ourselves, see how we're doing? The usual, the standard sort of performance measures. Although I will say, I think that I used to be on faculty at Jefferson, and I, love my department, and I thought it's wonderful. But at least as of the time I left, we weren't doing nearly as much sort of clinical outcomes type stuff and evaluating the staff as much as we do at the health department. That may have changed. I don't know. I'm not in that practice anymore. But there's a lot of ongoing evaluation. And then as my job as a clinical director is to really day-to-day feedback of providers, making sure that they're sort of meeting expectations. Yes?
Why do you think that they put mental health at the bottom of the list? Being so right now with the economic downturn, I'm sure you're seeing a lot more patients.
Yes.
Require
Right. Everybody hear that question? Why, she's referring back to what I said here, that why mental health may not be showing up on this list. I think the reason they put it is it has to do with the billing. It's a billing thing. So many of our patients are quite ill and they need various tests or, they ongoing care. So they need blood tests and things like that for their diabetes or their hypertension, and you have to link the diagnosis with the lab. And if you only have 4 diagnoses to link with various labs, you got to put those 4 that are most supportive of the lab work on the encounter form. And then the other stuff is then in the chart. It just doesn't get on the encounter form. So if we were to do a better audit, if we were to do better evaluation of really what the diagnoses were by chart audit as opposed to just the encounter form, I'm sure it would be up there. The other thing, though, is I think in primary care, honestly, we're not great about actually identifying or noting, documenting behavioral health stuff. I think identifying we're okay, but there's still this stigma where it's like, oh, I can't put down that this person has depression or this person has, anxiety or, bipolar disorder, whatever. So there might be a little bit of that too, but I really think the bulk of it is because of the first reason. Okay, so who are the uninsured? I think you guys kind of you get this. They don't have insurance. They have limited insurance. Prescription coverage is a huge issue. They do not or cannot access care. So again, this speaks to that thing I talked about. Well, we've got, our kids. Why are so many of our poor children not insured? They should technically and in theory, on paper, they're insurable. So why aren't they insured? So I think that may have a lot to do with it. And then limited English proficiency and things like that go with immigration and fear, especially if people are not fully documented while they're here. So now let's talk about some of the stuff we do. And I'm gonna go through 3 cases to give you some examples of the work that's done in the health centers. Case number 1 is a 52-year-old male security guard, working man, okay, who has hypertension, hyperlipidemia, and hepatitis C. He has no insurance. Why doesn't he have insurance? Because he's over income. Because, he works at a job that because he earns, say he's got a family of 4, I don't know, say he earns, and so I may have these numbers not exactly right, but in order to qualify for medical assistance, you must make less than the family income has to be less than 150%. Let's say he's not a family. It's easier for people with kids. Let's say he's single. You have to make less than 150% of the poverty level of your household. So for a single man now, poverty is defined as, I think, $12,000 a year, $11,000 or $12,000. So if he earns more than, say in the realm of $20,000 a year or 18. He won't qualify for medical assistance. And he can't afford to buy insurance because it's $300+ a month. And he's trying to, so there are lots of reasons why this working man doesn't have insurance. And yet he has all these conditions that, are a setup for worse and worse health outcomes. So what can we do for him? Again, this is the health centers. He may end up, he may choose not to come to us, but if he comes to us, what we can do is we have him covered in many, many ways, I am happy to say. He doesn't have to worry about costs for office visits, laboratory tests, radiology, or medications, including the hepatitis C treatments, which I'll talk about more in a minute. In terms of cost, just one thing I want to say, in the last 2 years we have implemented, we actually do charge. We are not free. We charge for scheduled office visits for our patients on a sliding scale. That was something that was, fraught with a lot of hand-wringing, and, people resisted that for a long time. But by and large, it's going fine. The sliding scale is something like, I think, is it $5 to $20 or $10 to $20 based on your reported income? And if you didn't hear this from me, but if you just can't pay or are unable to, we're not going to shake you down, okay? But you didn't hear that from me. But people are generally very willing to pay that amount. And that's not for every visit. It's for your follow-up visit. So if you had to come in for something else, a TB test reading or something, we're not going to charge you for that. But when you come to see your doctor and you get a whole slew of meds and you get tests, yeah, you're going to get charged $10, $15, $20. So let's talk a little bit about pharmacy. Last year, we filled over 500,000 prescriptions, which is a lot for us. There are many mechanisms that we get medications for our patients. Now, let me say this, be clear about this. People see this and they think, great, I see this patient and he or she will come in to my clinic and, I'm not at the health department, outside, and I'll take care of him for, his hypertension, but I'll just send him to the health center to get his meds. It doesn't work that way. As much as we would like to, we are not a freestanding pharmacy. They have to be our patients. So if you want, what I've had to tell even my colleagues, that I worked with for many years when they wanted to do that, I'd say you're really not serving your patient. If they don't have insurance, it's best if they just transfer their care to us, because not only their meds can we help them with, but they're not getting their blood tests. They're not doing they're rationing themselves from a financial standpoint because they can't pay for this stuff. So just transfer their care. So the pharmacy services are for our designated patients, and you can become our patient. You just can't be sent by your primary care doctor on the main line and come and get meds from us. So we have a formulary that we negotiate prices with the drug companies, the pharmaceutical companies. We have an indigent care pharmaceutical program. Oh, I guess, yeah, that I don't even need that bullet, but whatever. We'll go on. We also, we use the Special Pharmaceutical Benefits Program, which for those of you who do HIV care might be familiar with that program, which is a fantastic service for Pennsylvanians. I think we are still a fortunate state to have this program that basically covers all meds, not just their HIV meds, but health maintenance, health-sustaining medications, cholesterol meds, BP meds, stuff like that, for individuals living with HIV, even though they don't have, and this is specifically for those who don't have prescription coverage. We also, so this isn't us doing it, but those folks are enrolled in our programs, and they may get their meds from our pharmacy, or they might get them from CVS or whatever. And then the patient assistance program that's been in existence, I think, since about 2006 that this young lady was referring to. So there are lots of meds that our city formulary doesn't have because it's too expensive for us. And regrettably, it's basically things like your basic, standard of care insulin. We just got Novolog on our formulary. We don't have any of the long-acting insulins. We don't have Levemir. We don't have Lantus. We don't have any of the mixed, Novolog, Humalog insulins. And to me, that's a crying shame. I mean, that's the standard of care for insulin-dependent diabetics, and we could not provide that stuff if it weren't for the patient assistance programs. And only in the last couple of years have we been able to figure out how to get that kind of stuff. So that's just an example. Plavix is another example. We don't have it on our formulary. Too expensive for us. I get these snarky calls and emails from various providers, and they say, well, so we see a lot of your patients, and we see that they come to us and they're on NPH, and what's kind of like the question is, what's wrong with you? And I have to nicely explain, like, we just don't, the patients can't pay for it, and we don't have it, but that's not the case anymore. Now we are able to get them the things that they need, and we're so happy about that. It's a lot of work, though. We couldn't do it without, the doctors, this is why I had it up here, the doctors used to have to do all the paperwork and the forms and everything for various pharmaceutical programs for medicines that we didn't, like Plavix, that we didn't carry. And it was we just couldn't manage it, and patients just weren't getting what they needed. So now we've got this. And we've got other programs that are rolled right into our pharmacy through Pfizer. As much as I'm not a big fan of Big Pharma, they have really come through for our patients over the decades, for things like, name brand, Lipitor, Norvasc, things like that azithromycin, things we did not have on our formulary that we needed to get for the uninsured folks. So that was case number one, and we could talk more about that. But basically, he's cool as long as he doesn't end up. We pay for the liver biopsy. We can most of the GI docs that we work with then get them hooked into programs that they get them hooked into programs that will pay for their hepatitis C care. So it's not just us. There are people out there. There are people in your facility and other facilities that are working on behalf of these. Of the uninsured patients. Case number two, a 35-year-old undocumented Latina presents with severe headaches. Her MRI showed a large aneurysm that needs to be clipped. Well, what are you going to do? We don't pay for that. That's crazy talk. We can't pay for that. So there is an entity called Emergency Medical Assistance for undocumented folks. Anybody here familiar with that? Does anybody know how that works? All right, so this is actually really a wonderful tool, and it has to be used judiciously because, we don't want to just put everybody that's undocumented on insurance because the resources are going to dry up. That's our fear. And we work closely with a fantastic agency called Community Legal Services that has helped to educate our entire staff, and they really need to help educate all medical providers everywhere about how to get patients emergency MA for life-threatening conditions for patients who are undocumented. It's not just undocumented. So in this case, in case two, she's undocumented. But for example, today we had a patient who is from Guinea, and she's like in her late 60s, and she has a whole slew of serious medical issues. And she's here legally, but she's only been here for 2 years. So she doesn't qualify for medical assistance because there's a rule that even though you've been here, and I'm not saying it's wrong, it just puts a lot of people in, a medical risk. If you've been here less than 5 years, even legally, you cannot get medical assistance. So fine. So if this woman developed some kind of potentially life-threatening or a condition that would seriously harm her health, like renal failure, say, for example, we could get her this same thing, this emergency MA. As it stands, we opted not to pursue it today at this time because she's doing okay. We're managing her medically. She's got a lot of stuff that could happen, but until it looks like she's going to have more medical needs, we're going to back off because, again, these resources are limited, and we don't want to, and it's time limited as well. Now we're up to 12 months, which is unbelievable. When I first started, it was 3 months. So it was basically like this lady who had the aneurysm, that was an old case. She had 3 months. It was like, okay, it's on. Go to the surgeon. Get it done. It has to be done within 3 months or else it'll be turned off. It has to be physician-driven or provider-driven. Now we have lots of other providers, not just doctors, MAs, nurse practitioners, et cetera. And it is income-based, but in most cases, the truly undocumented folks, they aren't showing any income. So they may be making money, but they're not showing it, so that's not an issue. But all insurance is income-based. Case number 3, last case. 45-year-old female office worker, works part-time. Was found to have a breast mass by routine screening mammogram at the health centers. She's uninsured and doesn't qualify for medical assistance, again, because she's over income. She works, but she's the working poor. She is above that 150% level for medical assistance, and her job doesn't provide, or the cost is too high for her. Well, unfortunately, she has a breast mass. The good news is she's one of our patients, and we can cover the cost of the breast biopsy through, we will just cobble together whatever we can. And I have to tell you, the folks who do this are amazing. They put together all these programs, and then the difficulty is translating everything they know in their offices and to us, the providers, and that's another big challenge. But this program has been around long enough that we got it down. So, like I said, it's bad news medically, but the good news is we can pay for the workup, the biopsy, and unfortunately, When your pathology comes back positive, we can't pay for the surgery. The grant doesn't cover, it covers up to mastectomy, but no chemo, no radiation. And that's a problem, except for there is another, so she's found to have a positive pathology, another fantastic, you must think I love these programs. Like, I just go home every day and dream about another program that I can learn about. But really, in practice, it's just, you know, it's the greatest thing to be able to put this stuff into practice and improve people's health outcomes. So this program is called BCCPT, Breast and Cervical Cancer Prevention and Treatment Program. Again, another fantastic thing that I don't know where it came from, but we've got it. We meaning, you know, Philadelphia is able to serve those who need it with this program. This allows for full medical assistance for up to 12 months to an uninsured women with known breast cancer or cervical cancer. So they have to have positive pathology. You have to have evidence of positive pathology, and you have to fax it into the office, the big black box of the office that then gets them the insurance. Eligibility is diagnosis dependent. Non-citizens are ineligible. So again, for example, my 60-something-year-old lady who, if she had had it, that I talked about earlier, who's only been here 2 years, even though it's she's here legally, she wouldn't qualify because she's not a citizen. She'd have to go through that other program that we already talked about. You can apply for an extension. So if the woman has been on treatment for 12 months and is still on anything, Femora, tamoxifen, or receiving chemo or radiation, well, they usually don't receive radiation for more than 12 months, but you know, any kind of treatment you can apply for extension. And the patient has to apply through a Healthy Woman site. Now, this is an example of one thing where I'd say, okay, so we, the health centers, because of like our obsession with, you know, programs and process, we have this down pat. But this is something that other entities could really use, you know, knowledge of. And, you know, I've worked with, and obviously, you know, it's not Drexel because I don't work with Drexel, but one of our contract hospitals who do great job for us, you know, they see patients like this probably more often than we do, but they don't know what to do. They're like, oh, well, you know, and they might try to get them, I know what they do. They try to make an agreement with them to pay for half of the treatment, or, you know, all that kind of craziness. If they knew about this, they would just have to implement it and it would be done. So there's still a gap in communication. So it's not like, well, only the health department can be a BCCPT site. No, there just has to be the will of the institution. Same thing with emergency medical assistance for undocumented folks. These things are out there, and the medical community, it would behoove all of us to be aware. I mean, just like there's probably lots of stuff I don't know about, but I doubt it. But, you know, I think we need to talk to each other, and I kind of have been pleading with them to please get in service by community legal services, but no takers as of yet. So who provides medical care? So now we're kind of moving out of the realm of just the health centers, and just, you know, so because I want to make sure I acknowledge all of my colleagues who are just doing a fantastic job. Who provides medical care for the underserved in Philadelphia? So besides the outpatient public health centers, you guys are. The hospitals often, you know, so my very sick patient, who then has to be hospitalized emergently or they're not sick, or they, you know, they had a ruptured appendix, or, you know, something happens that's sort of more catastrophic, they get admitted to a hospital. Well, the hospital's now taking over. That many patients will, many admissions will be reimbursed by medical assistance, but many are not. And there's a lot of, you know, how should I say, compassionate care being provided by hospitals. And sometimes not so compassionate, but, you know, by and large, compassionate care. So we talked about the health centers. There's also the FQHCs. They are like us, the federally qualified health centers. So which ones might you guys know? Maybe Maria de los Santos down up in North Philly. I'm trying to think what else is, oh, Fairmount. You might know Fairmount. It's not too far from here. They're one of them. There are a whole bunch of them. They're great. They do wonderful work as well. They do a lot. We're kind of like sister centers. We do a lot of the same kind of work, but I will say, and this is not me being biased, I think that they have a little bit more, they don't have as many resources as we do. So the scope of services that that folks can get without charge is probably a little more limited for the FQHC centers than it is for us. And then, of course, then you've got your emergency rooms and individual providers who are trying to do their best. But I think for individual providers that are in either private practice or even hospital-based practice in, one of the what do they call it? Outpatient offices. You have to think about what is best for my patient. I want to keep my patient. They like me. They want to continue to come here. But are you really doing them a service if they're foregoing treatment and care that they can't, because you might write off your office visit, which from what I understand people aren't supposed to do anymore. But are they getting their meds? Are they getting their tests? Are they getting their health maintenance? So people need to think about that. And then there are unique populations that, it amazes me how many patients we see, given how challenging it can be to be a patient at one of the public health centers, particularly an adult patient. Again, for kids, it's a different story. For kids, it's great. I think. I'm a parent. I think about it, it's like you call, you come in, you get seen the same day. In most of the centers, some of them are more busy are busier than others. But for us, if you come in as a walk-in or a hospital discharge, you will wait all day to be seen. Now, you will be seen. You will be seen by a nurse. Somebody will talk to you. And most likely, if you need to be seen by a doctor, you will be seen that day. But we're a tough system. We're resource poor. We're not just mean and surly. We're just, we're overwhelmed. So there are populations, there's a new one. I don't know what happened there. There are populations that just don't have the patience for us. I've had lots, and the biggest one is this group. They cannot sit there for 3 or 4 hours and wait to be seen. Now, if you have an appointment, you might not wait 3 or 4 hours. You often are still waiting an hour or two for all your care, your lab, your x-ray, your doctor, all that. But a lot of these folks don't have the patience for us, and they probably don't have the patience for any standard outpatient setting. And so, we shouldn't just write them off. There are efforts out there to try to address the unique needs of these vulnerable populations as well. I don't have any answers, but blah, blah, blah. Yeah, but I know of some of the strategies that we use to try to address these even more vulnerable groups. I have competition. You have to think about populations and so why, again, going back to that number of the high rate of lack of insurance in poor children. Why is that? It may not, in those families, there may be other comorbidities. There may be other things that prevent the ability to access the services and the care that they need and go through this paperwork that's required. The parents may be sick. The parents may be infirm. The parents may be undocumented. It's all kinds of stuff. So again, comorbidities and competing priorities. But having said that, it's not just, you and me and the health centers and, whatever, trying to help these people that are the most vulnerable. There are other agencies that are really sort of out there saying, we're here, we want to try to help you, help facilitate and navigate systems for the most vulnerable. And again, a good example is Community Legal Services. PHMC is great. They provide lots of sort of services and care and different sort of alternative medical settings. And we'll talk about this, but I don't know if Drexel has this, but a lot of the medical schools go out and do, their various indigent care clinics for homeless and this, that, and the other thing, which may be, limited in scope, but communicating the trust and the care to vulnerable populations so that they will have more faith in institutions like medical institutions, that's a remarkable thing. So even though those services may be limited, there's the goodwill that's going on there, trying to help sort of draw and guide people into care. We do know that on-site services yield greater success at integration to care, especially in the most vulnerable populations. And the other thing that's really important in these highly vulnerable populations is trust and speed. So again, people going on, medical students and other students going out and providing services, as limited as they may be, it helps to instill sort of the trust in sort of the medical community as a whole. And I really do believe that. There are a few small examples of successful outreach to particularly vulnerable, underserved. So Prevention Point Philadelphia, I used to be on their board of directors, and I used to volunteer for them. And they had this, again, limited scope, but of on-site medical services. And I have to, I regret to say that I'm not actually sure what's going on with them right now because I haven't been as involved. But there would be once every, I think they still do this, but in addition to their needle exchange that they do for clean needles, hooray, clean needles, they do medical care, I think, once or twice a week. And again, it's often through medical schools. I know Temple was involved, Jefferson was involved. So there would be a preceptor and there would be students and they would, give shots and diagnose and treat for abscesses and give asthma meds and stuff like that. School-based STD testing, I love this. They go out to the high schools and the health department has this down pat now, and they will get all these kids that, with the parents' sort of consent, to get STD testing. And let me tell you, we find a lot of stuff out there that we would not have found otherwise, and some of it is actually quite sad, but at least we're getting the care, they're getting them into care when they would not have been. And then another example is Youth Emergency Services, which is not too far from here. Again, an agency, a small, a nonprofit that takes care of homeless runaways. And their medical director is a very good friend of mine, and I've worked there. It's a great service. They not only, so they've got the homeless shelter for these youth, but they also provide, limited medical care on site. So the challenges are big, resources are the biggest issue, and so it's really about, I really need, what do I really want besides behavioral health is like lots of money to hire lots more doctors so that we can, or nurse practitioners, so that we can, provide the care that's needed. But it's not as simple as that. So we're, basically cobbling together, and again, very effectively, as I hope I've conveyed, various programs and things like that to try to do the absolute best that we can. What are the other challenges I mentioned? Communication and integration of services. So I know about this stuff, but does Dr. Ume, who's across the street from me, does he know about this stuff? Probably, he might or he might not. He's a real doctor. He's a good guy. Or the hospitals again. All of us talking to each other and using and accessing the resources that are out there. There are attitudinal barriers as well, of course. They come from within institutions. They come from the community. I work in West Philadelphia, so I've got a lot of, there's a pretty large immigrant population, and there's been a lot of, we're there, like we want to put up signs, we're here, we want to take care of you, we have, French interpreters, and doctors are learning different languages, and the community still, there's a trust issue there for various reasons. I mean, I can speculate what those are, but so I don't think we're actually tapping into the community as well as we could, especially for kids and stuff, because it's possible that they have heard stuff. I mean, if they just come in and see how great we are, I don't think it would be an issue. But, they may not be ready to do that. And establishing competencies. This is a big deal. To me, this is kind of a big deal. This is, people that come to work for us, it kind of stopped happening, but when I first got my job and I didn't really know how to communicate to the doctors and the new providers what it is they were expected to do, and I got a lot of, I didn't go to med school for this, after the first few months. You see how much we have to do. That is not, the doctor with the stethoscope thing. It's a lot of social services, integrated care, communication, a lot of paperwork, medical. I mean, I am such an expert with, more than I ever thought I could be. I mean, I couldn't believe I was telling a hospital administrator how to do emergency medical assistance. It's really not rocket science, but, I have to do it every day. So, so establishing competencies and expectations. So now when they come in and interview, I say to them, look, this is what we do. You're not just going to be treating your, the asthma and the this and the that. And I think that's actually true throughout medicine. And so we get the people that are excited by this, okay? If you're turned off by this, don't even bother. And then, of course, there's the whole notion of political will. We have resources. Where are we going to allocate them? And I just have to put a plug, just an example of this is when our current health commissioner, who is I'm not saying this just because he's my boss, but he is like the greatest thing since sliced bread. He talked to the hospital. We were having a lot of trouble with this is my last slide. We're almost done. We're having a lot of trouble with the contract hospitals. At that point, we only had 2 contract hospitals for 8 public health centers. We had Mercy Hospital, and again, kudos to these hospitals. Mercy Hospital, whatever you may have heard about some of these hospitals in the communities, let me tell you, they stuck with us and they have helped our communities to no end. Well, we really had 3. Mercy Hospital for all of West Philadelphia, and Temple for almost all the other all the other health centers, for the contracts that I talked about, and Methodist for Jefferson only. They were dropping like flies. They didn't want to have, and Temple was threatening to cut the contract because there was a lot of problems. They weren't getting paid by us. It wasn't them. We were part of the problem. So as I understand it, I was not in on these meetings, but as I understand it, he got a picture of what was going on, and he went and talked to and negotiated with a bunch of other people, I'm sure. But again, it was his leadership that allowed this to happen, I believe, and the mayor, and everybody that was involved, I suppose, to change it so that now we have numerous, I think pretty much every hospital in Philadelphia is a contract hospital to some level to one of the public health centers. And that has been a huge, it took a while. Things aren't perfect. There are still challenges, but that was a huge shift. And so sort of examples like that, these challenges, they exist, but they can be overcome to some degree. So I promise, that was my last slide. So I'm here if you have questions. I'm sorry I kind of went on a bit. So if you have time, want to ask, yes? Mm-hmm. Right. Right.
And what they're finding out is that if a patient is seen within 30 days,
Right.
it reduces the readmission.
Right.
So you're getting some of the patients back, but they're having a hard time getting them on the schedule.
Right. Can I address that? Or did you want to say something else?
That looks like a win-win to me.
Right.
Where if you can open up your schedule, you make the contract.
Right. Well, here's what we do. And again, I can only speak for my health center because I suspect the same thing happens at the other centers. While we have a very first of all, opening up schedules, I want to tell you, a provider can potentially, at my health center, have 22 patients on their schedule for a 3.5-hour session. So, not possible. But we have an alternative. And they don't all keep. That's the thing. It's like, I've gone, don't even get me started on the dynamics of scheduling and the challenges therein. But they still have a pretty high kept rate in that we end up seeing anywhere from 12 to 18 people in a 3.5-hour session for schedules. Don't forget, we've got walk-in. So the way that this works, what I tell a hospital when they call me or a patient walks in, and the doctors know this, at our center we've got walk-in every day, pretty much every day. Sometimes we don't, but pretty much I would say 80% of our business hours we've got walk-in. So the hospital discharge patient is priority number 1, especially a sick hospital discharge person is priority number 1. So what I tell the hospitals is, look, I know that Dr. So-and-so, well, I know I'm the provider, but the better thing to do is to just make sure the patient has their discharge paperwork, send them to walk-in, present the discharge paperwork to the walk-in nurse, and they will be evaluated. They may not be seen that day, but they'll certainly be seen within 3 days or that week. So that's how. And then say that person is really sick, and they can't wait 6 months because that's our next availability at my center is 6 months for an adult. We get them in. We have add-ons. That 22 patient schedule is not an open 22. It's really a 14 for the public and then 8 more various levels of add-ons. Okay, but still, it gets filled up. So we can add them on. We can bring them back to walk-in. So we are attempting to address that for both, not so much just to be a friend to our colleagues at the hospitals, but also because patients need care. They cannot wait 6 months to be seen, for after an acute, exacerbation of their CHF or whatever. So hopefully we're addressing that, and we are trying our very best. But trying to squeeze them onto their own doctor's schedule it's doable, but it's not happening consistently. But walk-in should be. There was another question. I saw another hand, I thought. Anybody else? Okay. Well, thank you very much.
Thank you.
Welcome.